This recorded lecture will be going over Chapter 32, Childhood Communicable Diseases, Bioterrorism, Natural Disasters, and the Maternal Child Patient. Providing all children with the appropriate immunizations is the healthcare challenge of today. Most viral infections are contagious for 2 to 3 days before the characteristic symptoms occur. Home care is the preferred care setting for children with communicable diseases. Staff who serve food should not be assigned to change diapers. See the following healthcare promotion table for selected recommendations concerning excluding children with communicable disease from child care facilities or school. You can see these on page 738 and 739 through page 741. On page 742, you can read a review of terms. Many of these terms we have covered in MedSurg already. Children are often contagious during the prodromal period, but because the symptoms are not specific, they may attend preschool or another group program and then spread the disease. The age, sex, and genetic makeup of the child have a bearing on the degree of resistance. The child who has an underlying condition like diabetes, cystic fibrosis, Burns, or sickle cell disease will be more susceptible to certain organisms. On page 742 through 743, you can read over a review of the different types of immunity. The chain of infection transmission can be shown on figure 32.4 on page 742. All children suspected of having a communicable disease who are admitted to the hospital are placed on both standard and transmission-based precautions until a definite diagnosis is established. Disposable items should be used whenever a child is placed on transmission-based precautions. On page 743 through 744, you can read over a review of the different precautions that we institute for airborne, contact, and droplet precautions. Both the child and family need adequate explanations concerning the protective environment precautions. Caregivers with skin lesions on exposed areas of their bodies should not provide direct patient care until the lesions are completely cleared. Education of family members should be ongoing. Children must be taught to avoid using community hand towels. Many infectious diseases begin with a rash. Rashes can be described with the following terms on page 746. You can also see more about this in box 30.1 in chapter 30. Table 32.2 on page 747 will present types of immunization agents. The influenza vaccine, the pneumococcal vaccine, the varicella vaccine, and the RSV immune globulin are all available for children. Current vaccinations against varicella, hepatitis, influenza for children 6 months of age or older, as well as high-risk children, and pneumonia for children greater than 2 years of age are all available. The challenge is to make these accessible. The nurse is a vital link in educating parents about the need for immunizations. Parental consent is required before a child is vaccinated, and appropriate vaccine information statements should be provided and reviewed with the parents before administration of the vaccine. Routine immunizations are not started until 2 months of age, unless a high risk of infection exists. The nurse can educate parents and school personnel about immunization schedules and should assess the immunization status of each child at every clinic visit. The correct route of administration is important to achieve immunization. Correct storage of vaccines is essential to ensure their potency. Improper temperatures can reduce the potency of the vaccine, and there are often no visible signs of these changes. Vaccines cannot be refrozen after they have been thawed. The nurse should be aware of any backup storage procedures if a power failure occurs. If a child has a history of allergy, the healthcare provider should be notified before the child receives any vaccinations. Epinephrine should be available in the unit where vaccines are administered. And the child should be observed for a minimum of 20 minutes before he or she leaves the area. When a parent refuses immunizations for their child, the nurse should listen carefully for the reason and offer appropriate education. The nurse should be culturally sensitive and offer education concerning the value of the vaccine in addition to options. The nurse must be aware of when vaccines are due to be scheduled for administration, the immunization history of the child, the vaccines that can be given together, contraindications, the route of administration, and proper equipment needed. All patients should be directly observed for 15 to 20 minutes after receiving an immunization, and appropriate equipment for the treatment of anaphylaxis should be immediately available. Reducing pain at the site of injection, especially when multiple injections are required, should be considered. Parents should have copies of their child's immunization records. The immunization program for children in the United States is described in Figure 32.6, which goes over page 750 to 757. Contraindications to live virus vaccine administration include immunocompromised state, pregnancy, bacteremia or meningitis, immunocompromised caregiver in the home, corticosteroid therapy or immunosuppressive drugs, or a history of a high fever after previous vaccinations. Children from 4 months to 18 years of age who start the immunization process late or are more than 1 month behind should adhere to the catch-up schedule. You can also see this in Figure 32.6. Research concerning the development of new vaccines and the refinement of established vaccines continues at an amazing pace. The most exciting development in immunology is the use of immunotherapy for non-communicable diseases. Box 32.1 on page 758 presents details of the nurse's role in the maternal-child units during a disaster. Children are generally more vulnerable to biological warfare because their immune systems are not fully developed. They are also closer to the ground, so heavy particles from an aerosol-propelled agent may reach them in higher doses than a taller adult. A new drug that is developed to treat a bioterror or chemical agent may in reality be more harmful than beneficial to the pediatric patient. The routine hazmat decontamination procedure of stripping and total body washing may not be suitable for the pediatric patient. The thin skin of the pediatric patient may make dermal chemicals like mustard gas more dangerous to children than adults. A relatively small blood volume makes children more susceptible to fluid losses caused by cholera or other GI toxins. Gas masks are often not available in pediatric sizes, and the National Disaster Medical System protocol may not make provisions for pediatric beds. Table 32.3 on page 759 lists common diseases and their symptoms that can be spread through bioterrorism. Children listen to television and to their trusted adults who are expressing fears. They may lose loved ones or friends, and they may play out their own fears with toys, in art, or through altered behavior. The basic role of the nurse in a disaster is to establish safety. Children may not understand what is happening, and they may be separated from familiar places and faces, but they can respond positively to helpful adults around them. Nurses can help parents meet the developmental needs of their children during and after disaster strikes. The American Medical Association has provided guidelines that state that the family should keep several days' supply of food, water, pet food, warm clothing, blankets, copies of vital documents, and toiletries on hand. Children should be taught the importance of keeping personal identification with them at all times, and how to call for help when needed. Although the ABCs of emergency triage for adults do apply to children, a pediatric quick examination includes the airway, breathing, circulation, and mental status. The pediatric patient has a proportionately larger body surface area and thinner skin than an adult. Children may also suffer increased pulmonary problems from the same exposure as adults. The immature blood-brain barrier and increased central nervous system receptor sensitivity could increase the susceptibility of children to the effects of nerve agents. Vascular access may be difficult in the pediatric patient, and dosage calculations for varied kilogram weights will increase the challenge for safe medical therapy for this population. Jim Broslow and Bob Luton have developed a color coding system known as the Broslow tape to reduce medication errors in children. Their systems include a water-resistant pediatric antidotes for chemical warfare tape, which measures the child's length to determine weight and color zones that correlate to safe dosages of specific emergency drugs commonly used in bioterrorism attacks. This tape is used as a guide in emergency care in the field or hospital emergency departments. STIs can be transmitted by a pregnant woman to her unborn child and can cause serious problems in the fetus, like blindness, birth defects, or death. You can read a little bit more about this in Table 32.4 on page 761. Nurses who wish to help adolescents with STIs must create an environment in which the adolescent feels safe and at ease. Careful explanations will be needed. Most adolescents need to be drawn out and do not readily ask questions, even when they don't understand. Girls who are sexually active must be taught to take responsibility for their own health. The nurse assesses the person's level of knowledge and provides information at an understandable level. The most common STI in adolescents in the United States is human papillomavirus. Manifestations include the development of clusters of flesh-colored, cauliflower-shaped warts in the perineal area. Contact with the warts will result in spreading of the condition. A vaccine is available, and the CDC recommends both males and females receive the 2-dose regimen, at least 6 months apart, between the ages of 9 and 14, or a 3-dose regimen between the ages of 15 and 26 years of age. Screening of pregnant women and antiretroviral treatment have reduced the mother-to-child transmission of the HIV virus. In children with perinatal exposure, virologic assay tests can be used to test for HIV infection in children younger than 18 months of age. HIV antibody tests should not be used in infants under 18 months of age. As of 2014, antiretroviral drugs were approved by the FDA for use in children and adolescents. Dosing ranges for children will differ from those of adults due to reduced absorption, increased elimination, and an immature liver. Psychological support for these children is paramount. Prevention is the core of education related to HIV and AIDS. Education of adolescents should include methods of transmission, hazards of IV and illicit drug use, and the importance of safe sex practices. The health education curriculum in elementary school for students and staff should include information concerning HIV and AIDS prevention.